Hello, sir. I'm Meghanshi, a third year medical student, and I'm here to present a clinical case discussion on COPD.
Hi folks, this is Dr. Patil and I will be moderating this case presentation by Dr. Meghanshi. The case is about a case of COPD, right? Let us begin.
So, sir, my patient details Mr. XYZ, aged 65-year-old male, resident of Lucknow, shopkeeper by occupation, class 5th pass, and informant is his wife, and she is reliable.
Okay, let's proceed.
Yes. So, sir, the chief complaints the patient presented with increased cough with expectoration since 20 days, increased breathlessness for last 6 days. Then, sir, history of presenting illness, increased severity of cough lasting for 1 month, which is insidious in onset and progressive, associated with scanty amount of sputum, white in color, mucoid consistency, not blood tinged or foul smelling, which aggravates in cold weather, more in the morning with no positional variation.
So he has cough for 1 month, insidious
Yes.
onset and progressive. Okay, so normally when we write the chief complaints and the history of presenting illness, we should make it a point that we arrange them in chronological order, like the one that
Yes.
started first and then one that appeared recently. They should be in the chronological order. The second thing is when you deal with a complaint, if it is a long-standing complaint, especially in the chief complaint, mention that the complaint is present for so many days and recently there is worsening of symptoms and that is why he is presenting, right? So that gives an idea to the listener or examiner that this is basically a chronic case and not an acute case. Right?
Okay.
Otherwise, when you say that someone presented with cough acutely and you don't provide me the duration of overall duration of the illness, then I might think of pneumonia as one of the important differential. I might set aside COPD or bronchial asthma, right? Okay, let's proceed.
Yes, sir. So, sir, increased breathlessness for last 6 days, could not even move from his house to his workplace, that is just 200 meter away, progressed to present stage of breathlessness on performing daily activities, slightly relieved on bending forward.
Okay, so now that we're dealing with a respiratory case, at least at the outset, it looks like we're dealing with a respiratory case and patients likely to become dyspneic or breathless. So what is the grading system that is used for grading the degree of breathlessness or severity? Like we have NYHA for heart, right? Do we have something for respiratory system or we follow the NYHA itself here?
No, sir, we don't follow the NYHA. For dyspnea, we have Modified Medical Research Council grading for dyspnea.
Yeah, so every student should be aware about the Modified Medical Research Council grading for the respiratory illnesses, and that is particularly more useful in case of COPD. And there is also another tool called COPD assessment tool, right? CAT. CAT and MMRC you should be aware of. CAT is a lengthy tool, so you don't need to remember the components. But the Modified Medical Research Council, you should know what constitutes grade 0 to grade 4, right? One should be aware about. Okay, let's proceed.
Then, sir, there is no history of hemoptysis, chest pain, recurrent infection, rhinitis, sinusitis, fever, TB contact, orthopnea, swelling of legs, PND, sudden loss of weight, dysphagia, hoarseness of voice, joint pain, skin rashes, numbness of extremities.
Dr. Meghanshi, why do you think that it is important for us to ask about hemoptysis, chest pain, or orthopnea, swelling, and PND, or dysphagia and hoarseness of voice? Why did you get this history from the patient?
Yes, sir. So, sir, for hemoptysis, we are basically ruling out any kind of malignancy or tuberculosis infection. And then
Yes,
orthopnea, dyspnea, or swelling, we are actually ruling out any cardiac causes which are associated with heart failure, etc.
Yes, good. And why did you ask about the loss of weight, dysphagia, or hoarseness of voice?
Sir, again, loss of weight it is seen in tuberculosis, then hoarseness of voice for any malignancy. These we are
so any tumors, yes, so any tumors or masses of the airway, yeah, that is something that we are asking. Okay, let's proceed.
So, sir, the past history, multiple similar episodes in the last 2 years for which the patient was admitted. He was continuously taking some oral medication and inhalers for last 2 years for relief of symptoms. No history of hypertension, diabetes, asthma, and cardiac diseases.
So we should definitely pay attention to the past history about the hospitalizations as well as exacerbations, because that will facilitate us in categorizing the patient into ABCD group, and thus it will help us to manage the patient efficiently, right? Okay, let's proceed.
Yes, sir. Then, sir, personal history. He consumes mixed diet, decreased appetite, and has disturbed sleep. Bowel and bladder movements are regular. chronic smoker since 25 years, smokes 20 BDs per day. So the calculated pack years are 20 into 25 by 20, that is 25 pack years. And there is no history of other substance abuse.
Okay. So you have a patient with 25 pack years of smoking history is what you meant to say, right?
Yes, sir.
Okay. So you should tell me whether the pack years correlate with the risk of patient developing COPD and the risk of patient developing the bronchogenic carcinoma.
Yes, sir. So, sir, if the pack years are 15 in number, like 15 pack years are there, so there are chances of developing a COPD. And if the pack year number increases to 35, there are chances of malignancy development. Bronchogenic carcinoma could develop.
Yeah, so you're roughly right. So most of the patients who are diagnosed with COPD generally have a history of at least 15 pack years of smoking, and the risk of developing malignancy starts exponentially increasing after you cross 30 pack years, right?
Yes.
Okay. Let's
Yes.
proceed.
So then the family history, there is no history of similar complaints in the family, no history of tuberculosis, pneumonia, asthma, cardiac diseases, hypertension in the family.
Okay, so when we talk about COPD, what is the relevance of family history? Are there any genetic abnormalities that are associated with the risk of COPD?
Sir, in case of family, so due to overcrowding, tuberculosis could be a problem.
Okay, so overall, yes, when we're talking about respiratory illness, at this juncture, definitely you should take the family history, and tuberculosis, yes, crowding is an important thing in India. Apart from that, if you're particularly talking about COPD, right, we have a condition called alpha-1 antitrypsin deficiency.
Yes, sir.
Right, so that is one genetic abnormality. Though the number of patients of COPD having alpha-1 antitrypsin deficiency is less than 1%, one should be aware about that, right? So that is one condition. Okay, let's proceed.
Yes, sir. So then summarizing my history, a 62-year-old male patient who is a chronic smoker came with the complaints of dyspnea and exacerbation of cough and breathlessness for last 6 days. His symptoms show diurnal and seasonal variations and breathlessness that has progressed from grade 1 to grade 3 with multiple episodes of similar complaints in the past. Cough was productive and no history of blood in the sputum. From history, most likely there is a respiratory system involvement that may either be obstructive and restrictive diseases.
Okay, so I'll just stop you here. So we have an relatively elderly male. So we know that COPD is more common in males. COPD typically has a significant smoking history. So most patients accumulate that amount of smoking history once they are near the geriatric age group. We are dealing with a chronic case, and we are also dealing with a progressive case because his dyspnea is worsening over time. You're definitely right in considering either an obstructive or a restrictive respiratory disease as a cause. Okay.
Yes, sir.
So how do you differentiate between the obstructive and restrictive respiratory diseases?
Sir, for obstructive and restrictive diseases, we can use the pulmonary function test, and in that, the ratio of FV1 by FVC, if it is less than 0.7, it is implying obstructive, and if it is more than 0.7, it refers to restrictive disease.
Yeah, so there is no simple clinical methods to distinguish between an obstructive or a restrictive lung diseases, right? So we have to rely on PFT, and as you say, FEV1 by FVC ratio. That is the most important observation. If it is less than 0.7 or less than 70%, that is in favor of the obstructive lesion. COPD being an obstructive condition, we would be expecting that to be less than 0.7. And if the ratio is more than 0.7, that suggests that it could be a restrictive disease, right? Let's proceed.
Yes, sir. So, sir, examination. General examination, the
Yep.
patient was conscious, cooperative, and well oriented to time, place, and person. Moderately built and poorly nourished. Vitals, pulse 96 beats per minute, which is regular in rhythm, good in volume, normal character, no delay. Palpable vessel wall, no radioradial or radiofemoral delay, and all peripheral pulses were felt.
Okay.
Then, sir, blood pressure 130 by 80 millimeters of mercury, measures in the right upper limb in supine position. Respiratory rate 34 breaths per minute. Abdominothoracic, rhythm abnormal, breathing patterns. Then temperature noted to be 98 degree Fahrenheit and GVP was not raised.
Okay. So in this case, you did tell me that there is a little bit of dyspnea and patient is tachypneic, right? Respiratory
Yes,
rate is
sir.
high. Other
The
than that, we
respiratory
didn't
rate is
find
increased.
any gross abnormalities.
Yes, sir.
If I tell you that you have a patient with respiratory disease and his JVP is raised, what do you suspect?
Sir, JVP could be raised in cardiac abnormalities.
Yeah, so basically that should point towards the right heart failure, right? Which is a very
Yes,
common
sir.
complication of long-standing chronic respiratory illnesses, COPD or long-standing other ILDs. They can develop the right heart failure. So when the JVP is raised, that means probably you're dealing with a case of
Yes, sir.
COPD leading to right heart failure, or what we call as cor pulmonale. Okay,
Cor pulmonale.
let's
Yes, sir.
proceed. Yeah.
Then, sir, weight 60 kg, height is 168 centimeter. So the calculated BMI is 21.3 kilograms per meter square. No pallor, icterus, cyanosis, clubbing, lymphadenopathy, and pedal edema. Using accessory muscles of respiration, flared ala nasal, and pursed lip breathing.
Okay, so as of now, we don't find any evidence of the right heart failure. Neither JVP is raised nor there is pedal edema, right? Okay, good. When you are suspecting from the complaints to history, you're suspecting that this could be a case of COPD, always make it a point that you examine for flaps. Okay.
Okay, sir.
So that you can pick up a type 2 respiratory failure early. Okay, let's proceed.
So, sir, the examination of the respiratory system, upper respiratory tract, oral cavity appears normal, nasal cavity appears normal, and pharynx appears normal. Then the lower respiratory tract, inspection, no tracheal deviation, apex beat not visible. Then chest was examined, bilaterally symmetrical, barrel shaped, anterior posterior diameter is increased, hollowness in the supraclavicular fossa, and intercostal spaces are increased, no intercostal indrawing.
Okay.
Yes. Then accessory muscles of the respiration used, no dilated veins, pulsation, scars or sinuses, no spinal deformity or drooping of shoulder.
Okay, proceed.
Then, sir, palpation. All inspections findings are confirmed. No tracheal deviation. Apex beat left fifth intercostal space medial to midclavicular line. No tenderness over chest wall.
So give me a condition or give me an example of a condition where the trachea is pulled towards the side of the lesion or the abnormal lung, and also give me an example where the trachea is pushed away from the affected side.
So, sir, in tracheal deviation, it could be pulled towards the lesion when there is lung collapse, and it could
Yes.
be pushed when there is pneumothorax.
Yeah. So objectively, we can also assess whether it is a push or pull by looking at the crowding of the ribs. So if it is a lung collapse on the affected side, there will be crowding of the collapse, right? On the other hand, if it is pneumothorax or if there is massive effusion that is pushing the trachea away, you will see that the intercostal spaces are increased in size. There is no crowding of ribs. Instead, there is wide spacing of the ribs, right? Okay. Let's proceed.
So, sir, the measurements, AP diameter to be 32 centimeter, transverse diameter 34 centimeter, and the ratio is 0.94. Chest circumference on expiration 98 centimeter, on deep inspiration 102 centimeter.
Okay.
Then chest expansion came out to be 4 centimeter. Then hemithorax, right side 48 centimeter. There's 2 centimeter expansion, and on left side 48 centimeter, 2 centimeter expansion. Tactile vocal premitus decreased on both the sides, and no palpable rales, rhonchi or rub.
So far, just to summarize whatever you have told me, the examination findings make it very clear that this is not a hemithoracic disease. This is a disease involving both the lungs or both the hemithorax, right? Otherwise, we would have noted the tracheal shift. We would have noted the disparity in the hemithoracic measurements. So that is not there. So we can conclude that we have a patient with a disease affecting both the lungs or both hemithoraxes, right? Okay, let's proceed.
Yes. On percussion, it was performed direct over clavicle and indirect over anterior supraclavicular, infraclavicular and mammary area. And in all these cases, a hyperresonant percussion was found.
Okay, so basically that means we are probably dealing with a case of emphysema, right? So hyperresonance should make me think either pneumothorax or emphysema. So in this case, because there was no disparity in the measurements that we took, so it is more of a diffuse disease. So I would be strongly thinking of emphysema. Okay, let's proceed.
Yes, sir. Then, sir, on auscultation, vesicular breaths were heard on both the sides. The added sounds like rhonchi was diffuse, heard on both the sides, and vocal resonance diminished in all areas.
Okay.
Then, sir, movements, all areas appear to move equally with respiration. So here
Okay.
in anterior, we have supraclavicular, infraclavicular, and mammary. It was decreased. Lateral, axillary, and infraaxillary, it was decreased, and as well as in posterior, suprascapular, interscapular, and infrascapular, it was decreased.
Okay.
Then the lateral axillary or infraxillary area, it was hyperresonant, as well as the posterior area were hyperresonant.
Okay. So basically, we have hyperresonant node with decreased moment, right?
Yes.
So still pretty strongly that we are thinking of emphysema, right? Okay. Let's proceed.
Then, sir, systemic examination. So, cardiovascular system S1 and S2 were heard, no murmur. Abdominal examination, soft, non-tender, and no organomegaly or mass was palpable. Normal bowel sounds.
Okay. Okay. So normally when you do a cardiovascular system examination in patients with respiratory illnesses, right, especially chronic respiratory illnesses, always make it a point that you look for the evidence of right heart failure on examination.
Yes.
Also make it a point that you look for the evidence of pulmonary hypertension, right? Loud P2, try to auscultate for it, and also see if you have a palpable P2, right? Okay. Let's
Yes.
proceed.
Then, sir, CNS examination. Higher mental functions were normal. Cranial nerves, motor, and sensory systems appears normal.
Okay. So what is the importance of looking for higher mental functions in patients with COPD?
Sir, any like we mentioned, there could be some encephalopathies could be associated.
Yeah. Yes. So particularly raised CO2 can cause the narcosis or hypercarbic encephalopathy. So one should definitely examine for higher mental functions.
Yes.
Okay. Let's proceed.
Then, sir, provisional diagnosis. So, based on anatomical, generalized involvement of both the lungs. Pathologically, we have chronic obstructive pathology of airways and alveoli and hyperinflation. The etiological cause, hyperinflation of the lungs, and risk factor, as we talked about, PD, smoking, and the age.
Okay. Let's proceed.
So, sir, the differential diagnosis could be chronic obstructive pulmonary disease with acute exacerbation and acute
Yes.
exacerbation of chronic bronchial asthma or persistent asthma.
Yeah. So exactly, this is where the role of PFT comes into picture. Okay. Let's proceed.
So, sir, the pathophysiology of COPD. So, it could
Yeah.
be the Venn diagram of like inflammation, airway obstruction, and structural changes. These structural changes are hyperinflation. Then we have alveolar destruction, collagen deposition, glandular hypertrophy, and airway fibrosis. Then the airway obstructions, the oxidative stress, increased neutrophil, increased macrophages, CD8 count, interleukin 8 and TNF alpha increased. Then proteases, antiproteases imbalanced.
Okay. Proceed.
So the pathophysiology. So we have abnormal inflammatory response of the lungs due to the toxic gases, and thus the response occurs in the airway, parenchyma, and pulmonary vasculature, which will lead to narrowing of the airway and then destruction of the parenchyma, that is resulting in emphysema. And the irritant will irritate the airway, and then as a compensatory response, excess mucus production would be there, thus leading to inflammation and cause the mucus secreting glands and goblet cells to increase in number. Thus, more mucus would be produced, which will result in thickening of the bronchial walls and narrowing down the lumen, and mucus plugs would be formed in the airway.
Okay. Let's proceed.
So, sir, similarly, this diagram shows that the thickened and narrow bronchioles with excess mucus and destruction of the alveolar walls in the COPD.
Okay.
Then we have types of COPD, that is emphysema and chronic bronchitis. So this is
Yeah.
the difference between bronchitis and emphysema. As we see in bronchitis, the appearance are known as blue bloaters, whereas in emphysema, it is pink puffers, commonly referred to as. Emphysema is seen in elderly, that is 50 to 75 year of age group, whereas bronchitis in 40 to 45. The dyspnea is severe as well as early in emphysema. The cough is later, it occurs and it is scanty, whereas a copious amount of cough is seen in bronchitis. The infections are common in bronchitis and respiratory insufficiency is repeated. Cor pulmonale is commonly associated with bronchitis, and airway resistance is increased in bronchitis. Elastic recoil is normal in bronchitis, whereas low in emphysema, as we know, due to the destruction.
Okay, yeah. So there are some important points to learn here. The first point I want to tell you is that today it is really difficult to distinguish between a blue bloater or pink puffer. That is traditionally being discussed. But mostly the patients of COPD that we see today are a mix of both. So they have some degree of emphysema, some degree of chronic bronchitis. Right? So only when the bronchitis is predominant and there is very minimal or no emphysema component, that will typically fit into whatever findings you described. Similarly, emphysema is the predominant and there is no bronchitic component, that will typically fit into whatever we described. Right?
So, sir, the gold criteria for COPD severity, it could be at risk, mild, moderate, severe, or very severe, depending upon the symptoms and the spirometry finding. So the FE1 by FVC ratio is less than 0.7 in all the cases, but the FEV1, so it is 80%, then it is mild. If it is 80 to 50%, it is moderate. 50 to 30, it is severe. And if it is less than 30%, it is very severe. Or even if FE1 is less than 50%, predicted with respiratory failure or any signs of heart failure, it is categorized under very severe COPD.
Yeah, so a severe case with the evidence of respiratory failure, right, or heart failure, right heart failure per se, yeah, that can be considered as very severe. Right? Okay, yes. Let's proceed.
So then the approach to patient with approach to COPD patient, we have essentials of diagnosis like history of cigarette smoking or any other chronic inhalational exposure. Then we have chronic cough, dyspnea, and sputum production.
Okay, see, one important point again. So when we talk about the essentials for diagnosis, right? In India, for females, the most common cause for them to develop COPD is burning of wood for cooking. Right? That is an important exposure, which is the most common cause for COPD in females. So for males, obviously it is smoking, but for females, that is the most common cause. Right? The domestic, what you call as chula, right? That is responsible for COPD in females. Okay.
Yes. So, sir, then essentials of diagnosis, rhonchi, decreased intensity of breath sounds, prolonged expiration on physical examination, airflow limitation on pulmonary function testing.
Yeah.
Then we have general considerations like the term COPD has evolved from an umbrella term for the chronic bronchitis as well as emphysema that refers to a clinical syndrome of chronic respiratory symptoms, then structural involvement and impaired lung function arising from multiple causes that results in airflow limitation, and that is not fully reversible.
Yeah, so this is one important point for us to learn, right? So your last statement says airflow limitation that is not fully reversible, right? Yes. So fully reversible airflow limitation is characteristic of bronchial asthma. That is why we do that bronchodilator reversibility test. So in this case, slight improvement may occur when you give them bronchodilators, but not complete or full reversibility is not known to occur. Right? Okay, let's proceed.
So, sir, the risk factors as we talked about, the cigarette smoking and other toxic gases inhalation.
Yeah.
Then we have environmental tobacco smoke, occupational dusts and chemical, indoor air pollution from biomass fuel used for cooking and heating in poorly ventilated buildings. Then outdoor pollution, airway infection, environmental factors, allergy. Then we have some hereditary factors like alpha-1 antiprotease, that is alpha-1 antitrypsin. Then atopy and bronchoconstrictions in response to non-specific airway stimulation. These are important risk factors.
Yeah, so there's one more point I want to tell you, that patients who are having bronchial asthma, right, they are also found to be at increased risk of developing COPD. So there is an entity called asthma COPD overlap, where both asthma and COPD occur in one given patient. So if you're asthmatic or you have atopy and allergy, your chances of developing COPD is relatively high in comparison to someone who doesn't have asthma or atopy, right? So, okay, let's proceed.
So, sir, the signs and symptoms, we know the common age presentation of 40 to 50 years, then cough with sputum production, shortness of breath. Dyspnea initially occurs only with heavy exertion, which progressing to symptoms which are at rest and in severe disease. Then exacerbation of symptoms beyond normal day-to-day variations often include dyspnea and increased frequency of severity of cough, increased sputum volume, increase in sputum corrector. Then infections, viral are more commonly involved than bacterial, which precedes the exacerbation in most patients.
Yeah, so if there is a question asking you what is the most common cause for exacerbations in patients with COPD, the answer has to be viral infections. Infections overall, viral more likely than bacterial, right? Yes. If there is a question asking you what is the most common cause for exacerbations in patients with bronchial asthma, right? There the most important cause is non-compliance to medications. not taking the inhalers on time or properly. That is an important reason for bronchial asthma exacerbations. COPD exacerbations are characteristically triggered by viral infections. Yeah, let's proceed.
So, sir, the late stage COPD characterized by hypoxemia, pneumonia, pulmonary hypertension, cor pulmonale, and respiratory failure.
Yeah.
Then, sir, diagnosis based on the laboratory tests, we have sputum examination, the most common bacteria like Streptococcus pneumoniae and Haemophilus influenza, Moxella catarrhalis. Then, cultures correlate poorly with exacerbation, and we have ECG, which can show sinus tachycardia abnormalities consistent with cor pulmonale in severe disease and or supraventricular tachycardia and ventricle irritability.
Okay, again, one more important question, right? So you are talking about ECG. Yes, I agree, sinus tachycardia can occur. There may be abnormalities which are suggestive of cor pulmonale. Other than that, yes, patients with COPD are prone for arrhythmias, per se supraventricular arrhythmias. Okay, they can develop sinus tachycardia, they can develop atrial fibrillation, they can develop SVT, but there is one arrhythmia which is very characteristically associated with COPD, quite less likely to be seen in other disorders. There is an arrhythmia called multifocal atrial tachycardia, MAT, multifocal atrial tachycardia. That should come to your mind whenever an examiner asks the characteristic arrhythmia seen in COPD patient. That is almost exclusively seen in COPD patients, or almost exclusively seen in patients with the long-standing lung diseases, and quite unlikely to be seen because of other causes, right? Multifocal atrial tachycardia.
Yes, sir.
Okay, let's proceed.
So, sir, the arterial blood gas values unnecessary unless hypoxemia or hypercapnia is suspected, and it may show only an increased DO2 in early disease, hypoxemia in advanced disease, compensatory respiratory acidosis with worsening of acidemia during exacerbation.
Okay, yeah. So as you said, we don't need to really do the ABG for all patients of COPD, but when you're suspecting that there is hypoxia, which is very easy to screen, we have the pulse oximeter. It is little difficult to screen for hypercarbia, right? Hypercarbia can only be screened with either a ABG, or if you have the facility to do the end-tidal carbon dioxide detection, patient is on ventilator, maybe you can look at the ETCO to see if there is an evidence of hypercarbia, but otherwise you need an ABG, right? Okay. So always make it a point that you examine for higher mental functions and identify the evidence of hypercarbia clinically, right? So increased sleepiness, then the difficulties in making judgments. These are all early pointers that patient may be. Even early morning headache, severe early morning headache may be a pointer towards hypercarbia, right? So whenever you have such patients, you get an ABG done to document that there is hypercarbia, because that needs to be addressed. Okay, let us proceed.
So, sir, the single breath diffusing capacity for carbon monoxide, DLCO, when severely reduced, it predicts pulmonary emphysema. Also predicts exertional oxyhemoglobin desaturation associated with coexisting pulmonary hypertension. A 6-minute walking distance of less than 350 meters is associated with increased mortality.
Okay, so DLCO is another important test for us to do, because it helps us to distinguish between some closely related or difficult to distinguish DDs. Right? Yeah, and the last point you mentioned, that is particularly important, the 6-minute walking distance. Now it is becoming a very important tool for understanding or unearthing obscure diseases. For example, in patients with COVID, they may not be having the resting hypoxia. We make them walk for 6 minutes and then the hypoxia is unmasked. Yes, so similarly, in patients with COPD, we use that 6-minute walk distance. So if it is not sufficient, that means the patient's functional tolerance of hypoxia and hypercarbia is poor. So that portends a high mortality. Right? Okay, let's proceed.
So, sir, then the spirometry findings objectively measures pulmonary function and assess the severity. Early changes are reductions in mid-expiratory flow and abnormal closing volumes. FE1 and FE1 by FC ratio are reduced later in the disease. Lung volume measurements show an increase in total lung capacity, residual volume, and elevation of residual volume and TLC ratio, indicating air trapping. Yeah, so air trapping is pathognomonic observation in patients with COPD, right? Okay, let's proceed. And then the imaging studies, so radiographs of the patients with chronic bronchitis typically show only non-specific peribronchial and perivascular marking. Plain radiographs are insensitive for the diagnosis of emphysema. They show hyperinflation with flattening of the diaphragm or peripheral arterial deficiency in both half of the cases. In advanced disease, radiographs that show enlarged central pulmonary arteries may indicate pulmonary hypertension.
Yeah, so you may have some evidence of emphysema or pulmonary hypertension on X-ray, but X-ray is not a very sensitive test for that purpose, right? Okay.
Yes, sir. Then the chest CT, which identifies and can quantify the emphysema phenotype associated with loss of tissue. It also detects airway narrowing and walk thickening, characteristic of the bronchitis phenotype. Then we have Doppler echocardiography, which provides a non-invasive estimate of pulmonary artery pressure.
Okay.
Then, sir, this is a centrilobular emphysema coronal reconstruction of the dorsal lung parts, and it shows apical predominance of the disease and the morphology of the secondary pulmonary lobes. They are remaining visible.
Yeah, so basically, yes, CT is a better test when you want to document that there is emphysema. But in most cases, it is not required, right? So when you diagnose someone as having COPD, the diagnosis is based on PFT and a proper history and the PAC years. And then for management decisions, you have the GOLD guidelines where you're categorizing the patient. Severity assessment also doesn't require. All we needed was the PFT findings there and the little bit of clinical history. So the CT is where you need to rule out other closely related differential diagnosis. For example, if you're thinking of ILD, CT is a better test, right? For COPD, it is generally not required, but it can help you quantify the degree of emphysema. Okay, let's proceed.
Okay, sir. So then the treatment. So we have supplemental oxygen, long-term oxygen therapy, like 16 to 18 hours per day. Then hypoxemic patients with pulmonary hypertension, chronic pulmonary erythrocytosis, impaired cognitive functions, exercise intolerance, nocturnal restlessness, or morning headache are likely to benefit from home oxygen therapy. Benefits of home oxygen therapy in patients with hypoxemia includes longer survival, reduced hospitalizations, and better quality of life.
Yes. So supplemental oxygen therapy, what is called as LTOT, long-term oxygen therapy, LTOT, yes. Right? So there are a lot of studies which prove that there is a mortality benefit, right? There is a mortality benefit. There are hardly few interventions in chronic diseases where the mortality is reduced. So this is one of them, right? Then yes. You should know the indications when you start long-term oxygen therapy. You don't prescribe oxygen therapy to every patient who walks into your OPD with COPD, right? So it is indicated when SpO2 is less than 88%. Persistently, SpO2 is less than 88%, or slightly higher SpO2, but there is evidence of pulmonary hypertension. So SpO2 89% with the evidence of pulmonary hypertension on echo or various other investigations. If there is evidence of pulmonary hypertension and SpO2 is less than 89%, you will offer them the oxygen. And if it is less than 88%, regardless of whether pulmonary hypertension is present or not, you would offer them oxygen, right? So SpO2 should not exceed 94%, right? So ideally 90 to 92% is a sweet spot. More than 94%, then you're taking a risk of causing respiratory depression in the patient, right? Okay, let's proceed.
Okay. So then, unless therapy is intended only for nighttime or exercise, there is a 15 hours per day is required, and for most patients, a flow rate of 1 to 3 liters achieves a oxygen level of more than 55.
Yeah, so instead of SpO2, if you're looking at PaO2, yes, it should be maintained of more than 55. Okay, agree. Let's proceed.
Then, sir, bronchodilators. So they do not alter lung decline. That is a hallmark of the disease. However, many patients experience improvement in the symptoms, exercise tolerance, FEV1, and overall health. Ipratropium bromide, that is 2 to 4 puffs via MDI, meter dose inhaler every 6 hours, is the first line therapy because it is longer acting and without sympathomimetic side effects. The short acting beta agonist, albuterol, metoprolol, have a shorter onset of actions and they are less expensive.
Okay, so just to summarize, bronchodilators, yes, they make patient feel symptomatically better. Right? They can tolerate a little bit of exercise. Their functional capacity gets enhanced, but they don't have an impact on the mortality. They don't reduce the mortality, right? So as of now, we know long-term oxygen therapy is the one that reduces the mortality. Bronchodilators make patient feel good. They improve their symptoms, but they do not reduce the mortality. We can use the conventional bronchodilators or the beta agonists that we treat in patients with bronchial asthma, or we can use the LAMAs, like you told about ipratropium. So those are the options we have. Okay, let's proceed.
Then, sir, at maximal doses, bronchodilation with beta agonist is equivalent. And then the side effects of like tremor, tachycardia, and hypokalemia. And ipratropium and beta agonists together, they are more effective than either alone.
Yes, agreed.
Then, sir, long-acting beta agonist, that is LABA, that is formoterol, salmeterol, they are indicated. And we have antimuscarinic anticholinergics. They appear to achieve a bronchodilation that is equivalent or superior to what is experienced with ipratropium, in addition to the similar improvements in the health status.
Yeah, agree with this. Yes.
So, sir, in this, we see that the patients are categorized into Gold A, Gold B, Gold C, Gold D criteria. And according to the exacerbation and functional status with MMRC and CAT2 grading, accordingly, medications are prescribed. And this is known as staggered approach.
Okay, so guys, be aware that there is something called as GOLD guidelines, just like how we have a GINA guidelines for bronchial asthma, we have GOLD guidelines for COPD. So
Yes, sir.
at the time we are recording this video, this is 2022, but every year the GOLD guidelines are revised, right? So right now we have the 2021 GOLD guidelines. So when you're going for examination, whether it is your practical exam or whether you're MCQ based or university theory paper, be updated about the current GOLD guidelines, right? So as of now, according to GOLD guidelines, we categorize the patients into 4 groups, right? Gold A, B, C or D. For that, we are looking at their functional status, which can be assessed using the MMRC or CAT tool, as Dr. Meghanji told. And for their the second thing we are looking at is the history of exacerbations and hospitalizations. So based on that, we come out with this category, and then we decide what is the appropriate medication, right? So please watch the video that is there on the Proplider app for the GOLD guidelines, right? Okay, let's proceed.
Okay. So, sir, the inhaled corticosteroids, they are not considered as a first-line therapy in stable COPD patients. However, 3 large clinical trials of combinations therapy with inhaled corticosteroids and long-acting beta agonists, they show a reduced frequency of exacerbation and modest improvement in lung function. So, sir, we have phosphodiesterase 4 inhibitor, roflumilast.
Yeah, so roflumilast can also reduce exacerbations to some extent. So there are certain specific indications for that. So more of it you will learn from the GOLD guidelines. Let's proceed now.
Then, sir, oral theophylline. It is a 4th-line agent for patients who do not achieve adequate symptom control with inhaled anticholinergic, beta-2 agonist, and corticosteroid therapy. So the GOLD guidelines recommend theophylline only as a last resort if bronchodilators are unavailable or unaffordable.
Yeah, they come with a lot of side effects, right? We are all aware about. The tachyarrhythmia risk is significantly high. As such, we have already discussed the patients with COPD are prone to develop tachyarrhythmias. They're prone to develop atrial fibrillation, SVT, and the characteristic multifocal atrial tachycardia. And prescribing them the drugs which are pro-arrhythmic, they increase the risk of arrhythmias, right? And thus, the mortality rate is also high in patients whose COPD is symptoms are controlled using the theophylline. So they are last resort as of now. Okay,
Yes.
let's proceed.
So then, sir, we have opioids. So in case of severe dyspnea, in spite of optimal management, so we have morphine with 5 to 10 milligram orally every 3 to 4 hours, oxycodone 5 to 10 milligrams orally every 4 to 6 hours, sustained release morphine 10 mg orally once a day. Then sedative hypnotics like diazepams, it is given 5 mg thrice a day daily, and may benefit very anxious patients with intractable dyspnea.
Okay, so these are the proper postgraduate areas. I don't think anyone would question you about the role or indication for opioids in COPD or the role of the benzodiazepines in patients with COPD, because they come with the risk of respiratory depression. Right? So we are definitely worried about that. It is more of a very specialized niche territory, right?
Then, sir, BOD index, BMI, obstructive ventilatory defect, dyspnea severity, and exercise capacity.
Okay, so guys, be aware about the BOD index. You may get some 1 or 2 Viva OSCE questions about it. Mostly all the questions will be centered around the point, what are the components of BOD index, or if it is an MCQ, they will be asking you which of the following is not a component of BOD index, right? So she has already summarized about it. Okay, let's proceed.
Yes, sir. Then we have some management of the hospitalized patient with an acute exacerbation. So this will include the supplemental oxygen. Now we need to maintain it between 90 to 94, the saturation, and PaO2 between 60 millimeters of mercury to 70 millimeters of mercury. Then we have inhaled ipratropium bromide, which is given, as a 500 microgram by nebulizer or 36 microgram by meter dose inhaler with spacer every 4 hours as needed. Then we have beta 2 agonist like albuterol 2.5 mg diluted with saline to a total of 3 ml by nebulizer or by meter dose inhaler as 90 microgram per puff, 4 to 8 puffs via spacer in every 1 to 4 hours as needed. Then sir, corticosteroids like prednisone of 0.5 mg per kg per day orally is given for 7 to 10 days, and broad spectrum antibiotic cover is being given. Then we have chest physiotherapy in selected cases and lung volume reduction surgery in localized emphysema.
Okay, so lung volume reduction surgery is another frequently asked question area. When do you consider? So typically you will consider lung volume reduction. When we say reduction means we are chopping off a part of the lung, right? So that can be done when first thing is the emphysema is affecting only a localized area so that you can get rid of that area. Right? The second thing is that area should be easily accessible. Should not carry too much of complex operative procedures or operative steps, right? So usually when it is apical, it is relatively easy to operate. So apical localized emphysemas can be treated with lung volume reduction surgery. Broad spectrum antibiotics, I would take that as a controversial point because not all exacerbations are caused by bacterial infection. So one should definitely weigh in or think before prescribing antibiotics, broad spectrum antibiotics, whenever there is exacerbation, because most of the exacerbations are because of viral infections.
Viral infections.
Okay. So thank you guys. With this, Dr. Meghanshi gave you a brief overview of all that you need to know from the diagnosis to the management of COPD. There are some important areas which I have highlighted. Do spend some time on that. Be updated about the latest GOLD guidelines. As of now, we have 2021 GOLD guidelines. Pretty soon, we may get the 2022 GOLD guidelines. As and when they are available, we will be updating you. But right now, be aware about the 2021 GOLD guidelines, how we manage. There are certain vaccines which are introduced recently for the COPD patients. So you should be aware about that. And the 2021 GOLD guidelines also talks about the COVID risk and how do you handle COVID pandemic in a COPD patient, right? So you should be aware about all of that. Okay, so with that, we will conclude today's session. We will be again connecting with another interesting bedside case presentation with Dr. Meghanshi. Thank you all.
Okay. Thank you, sir.